AI is sprinting, but healthcare regulation is crawling. Can we protect patients without smothering innovation? Our guest for today is Sina Bari. He's a doctor and a leading medical device and information technology innovator. Sina completed his undergraduate training at Stanford University, where he studied electrical engineering and medicine. He then completed his plastic and reconstructive surgery residency at Yale University School of Medicine. While there, he also completed a fellowship in microsurgery and hand reconstruction. He has been recognized with the Presidential Honorary Career Award for Scientists and Engineers from President Barack Obama in 2016. Sina is the AVP at MedAI division of iMerit, which is a leading AI data company that powers advanced machine learning and artificial intelligence models. Hey, welcome to AI Revolution Digest, where businesses get smarter. I'm Jocelyn, and I'm going to show you how AI drives real results. And because the future is awaiting, let's dive right in. Every industry has its disruption moments. Now, for healthcare, the question is, will AI make medicine more human or less? To answer this question for today, let's welcome our very special guest for the day, Dr. Sina Bari. Doc, thank you for being here. Can you tell our listeners who are you and what is it that you do?
Thanks so much, Jesslyn. I am a physician by training. I was a surgeon, a plastic and reconstructive surgeon, but I've been with a company called iMerit for the last 7 years, and we help develop AI models. So we are very much the human side of it in that we build data sets in order to train models, in order to test them for regulatory standards, and audit them once they're out in the market. My specific focus is healthcare. So we work on a bunch of different applications. We work on ambient scribe technology. We work on a lot of radiology applications and then also some surgical applications as well.
So, regulation in AI, it's one of the largest things, but especially for healthcare, which is a highly regulated industry. So, AI moves fast, regulation in healthcare moves slow. How do we keep patients safe without killing innovation?
Yeah, so this is an area that we're very active in iMerit because we train all of these different systems. Once they get into the commercial level, we're often asked to keep an eye on them and monitor them and do audits and see how they perform in the real world. Typically, it falls under a system called governance, which we sort of borrowed from the world of cybersecurity. So when we think about governing a technology, we're kind of making sure it's safe for everyone to use. Within AI, we're specifically looking at applying an HHH model. So is the model honest? Is it harmless? And is it helpful? So you can have honesty is obviously accuracy of the model, but then something may be inaccurate, but inaccurate in a way that is not so dangerous, or inaccurate in a way that's very dangerous. Similarly, it can be accurate and harmless, but is it helpful? And so we're constantly analyzing the data that comes from these AI machines to see whether or not they're performing the way we want, whether or not there's bias against certain groups. There's an HH model that we use to evaluate these various AI models, and that's a infrastructure that we're currently working on deploying within hospital and healthcare systems. I think the sort of outlying question, though, is who is ultimately going to pay for that? Hospitals are businesses, regardless of how we may feel about that. Even, putting aside the sort of the profit motive and where that belongs within healthcare, we still have to pay people for being there and keep the lights on, and that they're very expensive. And so, hospital administrators constantly have to be thinking about, how to best deploy solutions in a cost-effective way. And so who will be doing the monitoring often depends on the liabilities, so the risk that is introduced if something goes wrong. You have to show that, it's cost effective to prevent errors. It has to do with insurance companies and what they will reimburse for. It has to do with vendors. potentially that might be something that they want to sell down the line, is not just the AI solution, but also the protection against drift and model decay and bias? Or is it going to be something that's ultimately mandated within a regulatory structure? And so that sort of post-release regulatory apparatus is still very much being defined. Pre-release radiology typically very much leads the way. I think it's the most established. And there, what we're typically looking for is measuring how accurate a system is and then comparing that to the standard of care. And so if you can show that it outperforms physicians alone, then that ultimately is going to be in the best interest of patients. For the most part, AI systems tend to be good for patients. They tend to be good for providers, and that they bring down burnout, and oftentimes they can be cost effective as well. So I think you need all three of those components ultimately for it to be a successful business.
So my question is, how did AI help doctors reduce burnout? Because what I understand is doctors are often they're often overworked. Like you're a surgeon, probably you've done surgery more than 24 hours, you're overworked. And that's the reason why that's where most of the mistakes come in, where proficients, they're just tired. And perhaps you're going to give me a patient's chart, and because of fatigue, I won't be able to work properly. So in what ways did AI help you manage that risk?
Yeah, I mean, I think that story is very much still being written.
Mm-hmm.
The low-hanging fruit is in documentation, right? So a lot of the time that doctors spend is not necessarily in providing care or making clinical decisions, but in kind of writing all of it down and creating the paper trail that's necessary in order to safely practice medicine. And that paper trail itself has a whole bunch of, potential for errors. It has the potential for being inaccurate or incomplete. And I think that's potentially one of the blind spots, is that within a lab, AI, when we test it, can be very it can be very clean within sort of fixed parameters. But in the real world, patients don't always know what medications they're on. They can be poor historians.
Mhm.
They can be, they can even, intentionally give you the wrong information, right? There may be drug seeking or secondary gain, some sort of, or, a different motive behind the information they provide you. And so that's, I think, one of the sort of dirty secrets of medicine is that there's a lot of psychology to it and understanding of people. And the way in which doctors communicate with each other is oftentimes coded, right? Because,
Mhm.
say, for instance, we have a patient who we think is not reliable in the information they're providing. Most doctors will not say this person, is
Yeah.
providing inaccurate information. They're not going to write that down in a chart, because it's very hard to prove that someone is not telling the truth, right? You
Yeah.
may have a suspicion, right? But if you put, you know, question mark malingering, or, suspect inaccurate, right? That's sort of code information to another provider that you didn't think that the person was telling the truth, right? And so there's all sorts of these little coded nuances that happen within the medical record, where you have an idea, but it's not something that you can prove, and so you need to document it. But at the same time, because it's not something, we don't have a test for pain, right? So if a
Mhm.
patient says they're in pain, we have to accept that on face value, even if we think that maybe the motivation there is seeking narcotics. And so, yeah, I think that that's part of what makes it challenging. Is right now we have a pretty sophisticated audience interacting with AI. A lot of
Mhm.
folks who are kind of logging into ChatGPT and running their case by them. Now that's an audience that just sort of by virtue of their, technologic sophistication, are self-selecting for, being really plugged in and aware of their own, of their own health. That's not necessarily true for the population at large.
Yeah, I totally agree with you. What medicine is actually more with psychology. For example, there's a rise of ADHD cases,
Mhm.
and there's some documentaries where people like my age may uh, try to get a diagnosis of being ADHD because they want to get ADDY because they think that ADDY is a study drug. It's abuse of medicine. Just like what you said, I think this is important when people think that AI is gonna remove doctors. That's not true. Doctors, this is where your ethics are gonna come in. You're deciding, is this, you want to be compassionate with your patient, but you also need to know what is, you need to be quite suspicious of why they want certain drugs, right? Just like what you said, maybe they're looking for certain narcotics because they're hooked on it. So my question now is, if the data is biased, when data is always going to be biased anyway, can medicine and AI ever truly deliver fair and equal outcomes? Like, for example, historically, medicine is always based on the male human body. And when medicine was still new, perhaps you heard the term double Ws, like whining women.
Mhm.
I don't know if you've heard it in the US, where it was this case where women are going to come in and they whine. They're often in their mid 30s or 40s. They go to the doctor and say, "Oh, I have discomfort on my uterus," and all the lab tests will turn out great. It was a time before we know the correlation between hormones and menopause. It was a time we didn't know what menopause was. So in the medicine world, we didn't know much about the female human body. So we just label women in their mid years in pain as whining women. So my
Mhm.
question now is, there's still a lot of data that we haven't discovered. And the data set we have is, of course, biased because of the history. In what ways can AI help medicine be equal?
So I think when we think about bias, there's a couple different ways to look at it, right?
Mm-hmm.
There's data, which often is biased because it's not representative of the population and whole. And historically, medicine has not been representative, right? And like you mentioned, there's the idea of like the hysterical woman.
Mm-hmm.
Hystericism was thought of as a problem in the womb that was causing emotional disturbance, and that term still exists as kind of the hysterectomy. And that is something that exists that sort of predates AI, and AI actually has the potential to address or improve on, because it doesn't come in with a sort of larger societal bias. It's only going to reflect the data, right? But
Mm-hmm.
if we as sort of agents and stewards of the AI are only collecting data that is misrepresentative, then yes, we will introduce bias during that way. And then there's also the sort of the bias that exists within the model, right? So separate from the data, but once you have, a model trained, then each, model has, the potential for bias. When we think about it in comparison to the human mind, putting aside sort of, racial and gender bias and inequities that arise from that. But aside from that, there's also bias that is very much a part of how we as practitioners practice medicine. I think it was an economist, Kahneman, who won the Nobel Prize for talking about fast thinking versus
Mm-hmm.
slow thinking. So type 1 versus type 2 thinking. And so type 1 thinking is based on a bias. It's based on a pattern recognition and sort of a stereotyped behavior, right? We wake up in the morning, we do our routine. We're not thinking through, woke up, what do I do today? I gotta think about hygiene. No, we're just kind of like, okay, I gotta brush my teeth and get ready,
Mm-hmm.
right? And it's sort of a rhythm, right? And so a lot of medicine is that. It's fast
Mm-hmm.
thinking, because that's how it happens efficiently, right? If you're in an operating room and you're doing an operation, you have to be in some sort of, almost like a flow state in order to be doing it well, right? You want to try and minimize the amount of sort of slow thinking, because the time is really important to to be efficient within an operation for the safety of the patient. And so separating out sort of fast thinking versus slow thinking is something that ultimately we're going to need to do within AI systems if we're going to have them operate as efficiently as the human brain does, which right now, that is an open question. We can still a long way from, the, the gigawatts of power that it would take for a human brain to replicate a human brain.
So my question now is, if someone were to give you 1 billion to invest in healthcare and AI for tomorrow, where would you put it?
So I think I would put it in diagnostics
Mm-hmm.
for global medicine. So I think that the barrier to technology globally and to care globally can really be helped by basically having these diagnostic abilities within at the hands of more people all over the world. That I think is going to ultimately do, the most for the most people, and that's something that the Gates Foundation is involved with, and a bunch of different folks that are trying to apply AI for good. And I think
Mm-hmm.
that's something that motivates me. Coming at it from as a practitioner, I think my ultimate calling is as a healer.
Mm-hmm.
So, and I think that what has happened, and this is a function of burnout, it's a function of the system that we live in, is that there is not necessarily diametrically opposed, but maybe sort of an uncomfortable bedfellows between the physician as compassionate person and the physician as scientist.
Mm-hmm.
Parents were both physicists. I have like a deep love of science, of a search for the truth. It's a big part of what I do. But to some extent, science requires us to be somewhat objective, somewhat disconnected
Mm-hmm.
from our patients. And so if we reach a point where, the science is better provided by these AI systems, if they are able to look at the data more precisely, more, and there's a lot of obstacles to there, and, whether it be multimodal or longitudinal, but if they're able to ultimately to be more accurate in their providing of the scientific side, then maybe where doctors go is further towards the compassion side and really go back to realizing what our work as healers would look like.
That's really interesting because I guess, okay, when I was young, I was really looking at medicine. I was considering it because my dad studied medicine and he became a lawyer. So I really understood when you said, I'm going to use science to really seek the truth. You're using technology. You're in medicine, you went to technology. My dad, from medicine, he went to law to seek the truth. And just like what you said, we have the facts, but as a lawyer, you also need to be compassionate. Same with the facts, and just like what you said. And I also agree with your point where if you're going to give $1 billion to help diagnose someone earlier, that's going to be better. Because I think more people die because of late diagnosis, or they
Mhm.
didn't even know that their family had a certain sickness because it was not dominant, and somehow it reappeared on him or her. And I think it's going to save more lives, and that's something I agree with. So my question now is, you said doctors are going to be more compassionate. So you're saying the technical sides is going to be commoditized because of AI, ChatGPT. More doctors or more medical students will have access to information that before it's only rich kids that have access to expensive tech books.
Mhm.
When my dad was studying medicine, it was very expensive to do Xerox. So he needs to spend, I'm pretty sure you did this as well. You need to
Mhm.
spend all your day in the library reading through books. But now we have iPads and ChatGPT to give us our data. So my question now is, how do we improve our bedside manner? Because I feel like for the longest time, if a student wants to go to the top medical school, like yourself, you went to Yale and Stanford, a lot of people are going to prep for the technical skills, are going to prep for those technical questions. But now you're saying it's because of AI, those skills are becoming commoditized, where you're not able to differentiate yourself just because you got a 10 out of 10 in your technicals. So, in what ways can we be more empathetic? Like, for example, you want to be a heart surgeon and your patient is Muslim. So, of course, she's not going to get a pig's heart. And it's very difficult to get a cow's heart. So, it's like having the bedside manner and cultural awareness is being more important in medicine. So, how do people cultivate that? Knowing that for the longest time, our education has focused more on those hard skills.
Yeah, I think it'll require a complete transformation of our education system. I when I think about if I have a friend or a family member or or myself, if I think about who would I see if I have this complex problem, this diagnostic challenge, I would go to the person who has who I had the fortune of meeting this type of person at Stanford, but a person who has an encyclopedic knowledge of the space, right? And oftentimes it's hard to even find these people, right? You have to kind of know, you have to be resourced enough to find these people. And it wouldn't matter what that person's bedside manner is, right?
Mm-hmm.
Similarly, in surgery, there are surgeons who I've worked with who are technically brilliant.
Yeah.
They are they are extremely precise at every throw of the needle. It's a perfect arc each time. There's no wasted movement. And it's essentially when we start thinking about these people, but they're terrible at the bedside, right? They don't want to do any of the consoling, and that's not within their wheelhouse. But they're the ones that I would see myself. They're the ones that I would
Mm-hmm.
recommend someone to see, because ultimately the that side of medicine, I would hope that they get from their family or friends, but at the end of the day, their outcome is going to be dependent on that person's either knowledge or their technical ability, and that's what I would be sending them to that person for, or even sending myself for, is that outcome, right? And I would put bedside manner aside. Technical expertise, when that knowledge base becomes ubiquitous, when it becomes, essentially, either you can say it's commodified, or you can just say that it, there's a more egalitarian distribution of it, then other things become important. So the the I still believe that there are going to be people who are going to be interested in healing other people. I think that is a calling, and I think that our current process actually turns people away from that. The burnout, if you go into any hospital and you go into, the doctor's lounge, it's like maybe the most depressing place in the hospital. Like no one's happy there, right? Because you feel like you're a part of a broken system, and you feel like you've got your finger, in the dam that's breaking. And the number of patients and the rigor of the work really, I think, just ends up disconnecting you from the compassion, from the humanity that for most people was the reason they got into medicine in the first place. And so
Mm-hmm.
I think that what it looks like, I don't think that on the other side of AI, at least, not in the near term, is a utopia wherein no one has any problems and no one is everyone is happy, right?
Mm-hmm.
I still think there's going to be suffering, and I still think there's going to be people who are called to alleviate suffering and feel like that is part of their life's work. It is very much still, to a great extent, a part of my life's work. I just felt like as a clinician, I could only do so much.
Yeah.
The impact I could have was meaningful for the people who I got to work with. It was but it was limited.
Mm-hmm.
I also think I sort of, I think I worked with enough people who were masters in their craft that I could say I was going to be good, maybe even great at some points, but I wasn't going to be a master. And so I had to think about, okay, well, if I'm going to contribute meaningfully, how am I going to do that? And that's where I started to, I started computer programming when I was 10 years old. My father had passed away. My mom had gone back to school. She was a physicist, and then she learned computer science, and she didn't really speak English well. So I would sit there with her, and I would, essentially translate these computer science books. And that's where I learned to initially program, and then I worked through high school and undergraduate, and then medical school, working in technology, and that's where I kind of built up those skills, and then and then I felt like that ability to innovate was really what excited me, and so that's part of how I transitioned into more of a tech-based role.
I think what you said was very interesting because the doctor I interviewed last time was Dr. R.V. Foundon. And that's the reason why I asked you the question about bedside manner technical skills. But perhaps this is a cultural difference between the West and Asia. Because in the West, you're more into the pills and you believe in that more. People in Asia, they're more into the herbal medicine. It's because historically we started with herbals and things. And so I talked to this doctor and he said, well, you can be the best technically, but if you cannot convince your patient to get the right treatment for him or her, nothing can be done. And it's the patient's right to refuse treatment, and he can do anything as a doctor. And he told me there are times when people would say, oh, do I really need to take those pills? Why can't I just take herbal medicine? So I think this is a huge difference between the West and Asia. And just like what you said, that oh, if I'm gonna die today, of course I want the one is the most technical skilled. But the
Um,
question is, can you convince me to do so? Can you
right.
convince me to take the treatment that you're telling me to take? And that's the reason why it depends on your take. Of course, your take is all doctors should be. That's the reason why I have the
Right.
board. That's why the reason why I have the board exam. That's why I expect you to have the technical knowledge. I guess it's the bedside manner would be, can you convince me to take the medicine that you suggest?
Yeah. Yeah, and I think that's the at least the near term future of
Mm-hmm.
AI. I don't know if you know at all about the history of elevators. Have you or your audience ever heard about that? So elevators were invented, in ancient Egypt, right? They were used, if you were the king and you wanted to get up on a higher level, you weren't going to take the stairs. Somebody was going to
Yeah.
pull you up with some pulleys and maybe a counterweight. But it wasn't until the 1800s when they started to develop elevators that went into buildings, right? Mechanical
Mm-hmm.
elevators. Sort of the late 1800s, turn of the century, they developed the sort of the autonomous elevator, what we would call today an autonomous elevator. So you go in, you press a button, and up until that point, there was an elevator operator, somebody who had a machine that they activated that moved you up or down, and stopped and opened the door. But the actually the operatorless elevator got invented 1892, patented 1895. It wasn't until the 1970s before we stopped using operators within elevators, right? If you go into an elevator now, there's not someone there who's going to press the button for you. But for that sort of 70 years, there was a gap where even though the elevators could run on their own, they didn't, because people didn't trust them to run on their own,
Mm-hmm.
right? You needed to have someone who was there as an operator. That's likely going to be what the near-term future of AI looks like, is that for medical legal purposes, for liability purposes, certainly the limitations in AI right now in multimodal and longitudinal data. But even if you take those things away, likely you're going to need a conduit, someone who is going to be able to work with these systems. I don't think that it's going to take 70 years like it took the elevator. I think we live in a much more technologically sophisticated world today. But if you told me it would take 20 years, or 30 years, I wouldn't necessarily be surprised. I think after that, it becomes very hard to predict what medicine looks like, what the world at large looks like, and that's a function of just how fast things are moving today.
Yeah, I totally agree when you point on it's about trust. Even though we have this new technology, do you trust yourself to be in this elevator? So that's the reason why you have human operators during that time, even though essentially you have the technology for them to be autonomous. And I'm taking this sociology course, and my professor said trust is not a feeling; it's a risk assessment
Mhm.
because you can put yourself in a vulnerable situation. So just like what we said, even though we have the great top model for AI for medicine,
Mhm.
There's always going to be this risk assessment in people's mind that, hey, how much can I trust the diagnosis of something? That's where doctors are going to come in, going to say how much I this, or to what extent does this data is applicable to me? Because there are going to be patients who are like that, and this is what one of the doctors I interviewed. He has experience where he had cancer, and from all of this diagnosis, people say he's going to die, and he didn't believe it because when he saw the data, it's all for Caucasians and he's Asian.
Mhm.
So hopefully with we can collect all data to make sure that it's more equal, right? Where it's representative of the population. That's your goal with iMerit, is to make sure we're gonna use this data, we're gonna make sure it's governance to make sure everyone's represented to give you the best care. So until we reach that point, there's always gonna be those skeptical people. And so it's okay to be skeptic. And I think that's the reason why we still need doctors.
Mhm.
I don't think doctors are gonna get out. Like if I'm in the operation, I would rather have you operate on me than a robot. Even though a robot you can give me all the facts. Scientifically speaking, you can say, the robot's gonna stitch my heart better than you would. Make surgery. You're a surgeon for my hands. So of course, one wrong move on you, I cannot write anymore. But I would
Mhm.
rather have you operate than a robot. Because I'm putting my trust in you. I
Right.
don't trust a robot to heal me, if that makes sense. And
Yeah.
as a patient, like if I'm going through something, I want someone that knows how I feel. Because
Yeah.
ChatGPT can never feel anything at all. So my question now is, there's always this bias that AI in medicine is always gonna improve, or innovation is always such a good thing. But do you think there's an era in medicine that will benefit the least in AI, and why?
An area within medicine that I think will benefit the least.
Yeah. Because
Yeah.
the bias is AI is gonna improve everything, or innovation is always good.
I mean, I think that is true. I think
Mm-hmm.
technology and innovation does in large measure move us generally in a positive direction, or at
Mm-hmm.
least it has, not without missteps though. You know, when you think about, early X-ray technology, I mean, we were using X-rays to, measure people's feet in order to put shoes on them because there was like there was ignorance around the risks around it, and
Mm-hmm.
certainly a lot of medications. I think that we will continue to have missteps when it comes to technology. That is, I think, an unfortunate part of advancement is that we don't always walk in the right direction. But there is an aspect of data, there is an aspect of medicine that fundamentally humans have pretty significant limitations around. So if you think about, all of medical knowledge, as well as a patient, coming to you with all of, their studies and their family history and their genetics, and then also all of these things happen longitudinally over a course of time. And then on top of that, you have new studies that are coming out in the literature, right? You have essentially a big data problem. You have information
Mm-hmm.
overload. And that's something that, humans we've done miraculous things around in terms of our own, specificities of knowledge, but there is sort of a limit to what we can ultimately get our minds around. Um, and that's where technology has some advantages, right? But the procedural side, if you take all of that and then need to do it in real time within an operation, that's, something that's very much still in its infancy. Like if you look at Figure or any of these robotics companies, I mean, they're like starting to fold clothes and things like that, and it looks great, but it's like, okay, we're kind of we're still kind of a distance from being able to, do complex procedures and things like that. So, that's where um, there's gaps. Empathy, I don't know that empathy is the gap, um,
Mm-hmm.
because human beings, like I said, human beings can experience burnout, and a
Mm-hmm.
function and a part of burnout is depersonalization and a loss of empathy and compassion. We don't have unlimited patience, right?
Yeah.
We don't have, you have a busy practitioner who, got a call from the school and
Mm-hmm.
their kid is sick. And so there's all of these sort of real world, issues that are going on and they just need to get, and they're already running late in clinic. And so do they give that last person the attention, they deserve? That can be really hard to do. People are forming these really deeply
Mm-hmm.
empathic relationships with it because of its patience, because of its ability to listen and provide encouragement. And so, and there's also value in anonymity, right? So,
Mm-hmm.
they've done studies where veterans have found that they are more open with a AI system than they are with a human provider because
Mm-hmm.
there's this sort of anonymity. So is it true empathy? No, I mean it's an approximation. It's of empathy, right? Because it's not actually feeling anything. But that doesn't mean that there isn't potential value in it.
I guess what you're trying to say is AI can give us all the right data. It's gonna give us the high probability of a diagnosis for a patient. But what's gonna distinguish a mediocre doctor to the great one, I would say, is a lazy doctor is gonna run all the tests. Because that's what a lazy doctor is gonna say if a patient has some illness. So I'm just gonna run all of the tests regardless of the cause because he's lazy. But the great doctor, a few questions, just looking at the patient, he knows what's wrong and he knows the exact test to ask. And that's the reason why when people come to you in LinkedIn, they say, you know what, all of this AI is going to replace people. I don't think so. And just like what we're trying to say is you can have all the right data, but it's more about which amount this data is the noise versus the one that's going to diagnose my patient the best. And that's the reason why we need to train people to see that. And there's just some things you just learn by experience, right? And I'm pretty sure there are some things you just know by being a doctor that you didn't know in medical school. I'm pretty sure there's a lot. So my question now is, how do you handle pressure when lives or career depend on your judgment?
How do we handle pressure? So I think anything that is, sort of performance related,
Mm-hmm.
requires practice. And it's sort of a stepwise approach to training, right? So you don't just start in the NBA, or you don't start as a concert pianist, right? There's all of these steps that you take prior to that build up your ability, your confidence, the amount of, your resilience to mistakes, right?
Mm-hmm.
All of those things take repetition, they take training. When we talk about,
Mm-hmm.
Malcolm Gladwell and 10,000 hours, right? We go through these times when, we kind of work our way up to that level, before we're ready for, the big leagues. A lot of that happens in surgical residency, right? So surgical
Mm-hmm.
residency is, notoriously extremely, time and time challenging from a time and labor perspective. But um you don't just jump into it,
Yeah.
from elementary school, right? You've worked through medical school at this level of efficiency and this level of intensity. And then, before that you worked as an undergraduate at a very high level. And so, you kind of work your way up and you build it like you build a muscle, right? You're sort of
Mm-hmm.
in training, and that's what it's called. It's training. And then you you have to, I think you have to build a community of
Mm-hmm.
people that, you can rely on. I think it's hard to do that and also, build a family. Because really what you want to do is you want to, be able to be self-critical, be able to continue to think about each decision you make in terms of the human weight of it and the consequences. And so I think it's important to, you know, the self-doubt is part of it. That's how that's how you continue to hone your skills. And it's what, it's what prevents you from like you have to know your limitations too.
Mm-hmm.
So there are complex cases that you have to, refer to a higher level of care, because ultimately it's what's best for the patient, and you kind of develop your skill set over time.
I guess what you're trying to say is it's about resilience. And if you can make small mistakes through the way. It's like, just because out of medical school, I won't put you into a surgical room ASAP. So that's the reason why we have residency, you shadow, you build your skill set before you go to the top leagues. And I guess the reason why people are not resilient is because perhaps you don't have the emotional support. Because as a doctor or surgeon, you're always at work. Some people would say they're married to your work. So your social support is low and you're overworked. So self doubt tends to come in. And that's the reason why suicide rates and people in the medical field is high. So being resilient and knowing the reason why you wanted to go to medicine, that's very strong for you. Just like what you said, your parents were in medicine, and that's what drove you to use technology because you're very passionate about this. You're just like what you said. I wanted to make sure that more people would have known what illness they had before they die. Because the number one reason why people die is because they didn't even know they had it. And I've known this because that's the reason why I ask you, if I were to give you 1 billion, where would you invest? Because it has shown me what you value. And this is the reason why you join iMerit. The question I always ask all my guests is, do you have any unpopular opinion in AI and healthcare?
Do I have an unpopular opinion? I don't know if it's unpopular. It's not one that I've heard other people
Mm-hmm.
say, but I think that we are on the brink of a liberalization of medicine, that will break it out from the pharmaceutical industry and
Mm-hmm.
from providers. I think that the day in which, and you kind of see this in the world of sort of peptides and people kind of self-administering things that kind of from
Mm-hmm.
the gray market. I think that trend is really at its infancy and will continue to grow. If you and it's tremendously risky, right? Because people are
Yeah.
essentially, administering
Mm-hmm.
administering themselves medications that haven't been through FDA approval.
Mm-hmm.
But I could see the day come when, you have a solid state peptide synthesis machine at home and ChatGPT, designs an enzyme or a molecule that's specific to you, that's specific to your
Mm-hmm.
biology. And that is what medicine looks like. Because where we are right now with that is it's essentially like crowdsourcing clinical trials. People are self-administering, reporting back results, and then, that is sort of like Wikipedia for medicine, right? It's like instead of running a clinical trial, it's like creating, and there's enough people who are like biohackers who are,
Yeah.
willing to experiment on themselves. I think that trend is going to continue, and it's going to be sort of it's going to be sort of on the outside of traditional medicine, and it's going to be probably a pretty important and powerful trend that will be ultimately AI assisted. I think that's probably not something that people are talking about much today.
It goes against the profits and the interests of the pharmaceutical industry. That's
Yeah,
it,
and
right? That's the reason why we have, just like what you said, people that go through the gray market or the black market to
mhm,
get certain medicines because it's so expensive. People
right,
die not because, there's a saying that my grandmother says, like, I won't have a sickness until I visit a doctor. There's this there's this bias that I'm not sick until I visit a doctor.
sure,
So I think that's the reason why people believe that if I go to a doctor suddenly I'm sick and I can afford it. Because these pharmaceutical companies are greedy. They don't want to liberalize their technology. That's why I go to the black market and just like what you said, I have biohackers. I'm gonna experiment myself. And I think it's more for critic on how much do we trust the pharmaceutical industry? How much do we trust the FDA that they're really saying yes to medicine that's really going to cure us versus we're just guinea pigs for it? I think it's a critique, and hopefully the role of medicine is to be more personalized. So, for example, if I have cancer, I want to have that's very personalized to my genome, and it's not just standardized. And if we were to have this personalized AI in medicine, there will be less people's gonna say, "I'm not gonna listen to you because your data set is all for Caucasians." I remember when I was in high school. I didn't go home for 2 years because of COVID, and I was in Singapore. So I left my home during the pandemic, and I was in hazmat suit. I have like 5 layers of gloves and
Mhm.
everything. And when the vaccine was approved in Singapore, I have some friends who were African descent, and he said, "Hey, do you plan to get the vaccine?" And she's like, "There's no way I'm gonna take it." This
Mhm.
girl, she's taking all the higher levels in math, science, and chem, and she got a full scholarship to study chemistry, engineering. So she's very smart. She knows all the sciences. And then she refused, or she was very hesitant to get the vaccine for COVID. I said, "Why is that?" It's because, she said, it's because it's not for Black people.
Yeah, and there's a lot
She
of,
said that.
I think,
Yeah.
there's a lot of distrust
Mm-hmm.
in various communities, and the distrust is born of a legacy of of racism and disparities in our healthcare system. So but my parents, they weren't physicians; they were scientists, they were physicists,
Mm-hmm.
and so I do have this love ultimately for science and for the truth. And pharmaceutical companies, there's an aspect of it that's profit seeking, but then there's also the reality that these
Mm-hmm.
the drug development is extremely expensive, and clinical trials are extremely expensive, and so all of the drugs that have to that fail on their way through the funnel have to get paid for by just the one drug that ends up coming through market. And so I think that if the future of medicine is hyper personalized, tailored to your genome, tailored to your microbiome, that will cause, I think, a shift in people's expectations and what they can trust. I think the again the it goes back to what is it that is ultimately the goal of people who are in healthcare. And I do think that despite it being lost for a lot of people on their way through the system, the core still starts with something wherein you are motivated by compassion and a calling to help people. And so we will find other ways to fulfill that calling, just as we have all through all.
Yeah, just like what they said. That's the reason why I agreed to do this interview when I
Mhm.
heard that you were in this field, is because I was very into semi personalized healthcare so that we can help more people. And that's the reason why, I made a point where perhaps this we can improve trust in medicine. I'll tell you a case. We have this Denvaxia vaccine. I don't know if you know this. It was a big scandal in the Philippines. What essentially happens was the government approved a vaccine for people with dengue. They approve it for from middle school kids. So they're very young kids. And all of these kids died. It's not a causation, but there's a higher correlation. And the reason for that is the government failed to tell the people that this dengue vaccine is only applicable for those who had dengue before, because it's a experimental vaccine.
Mhm.
So because of that vaccine, after that, we had COVID vaccine. Now, before this dengue scandal, the Philippines has like 90%. We're one of the countries with the highest rate of vaccinations. When you
Mhm.
tell someone to take a vaccine, we're going to take it. But because of that huge scandal, we dropped it to like around 40 when the first COVID-19 vaccine rolled through. So hopefully, it's like what I said, trust is such a huge thing. Closure and governance is such a huge thing. And that's like what you're trying to say is with iMerit, it's not only using about AI and medicine, it's more about the ethics and governance to making sure it is the right healthcare for you. It's the right diagnosis. And yes, we need to make a profit, of course. We need to make a profit to ensure that we give you the right amount of care. And that is what the core of iMerit is. We're not just making a profit for the sake of it. It's because you have a social responsibility to the people you serve. And that's why you even started iMerit in the first place, right? Because you believe technology is going to amplify your mission. Because if you're just a surgeon, you just help one, two people. But in iMerit, you can help millions or in the world as well as we liberalize this technology. So
Yeah,
thank you, Doc, for being here. Before we end, let's play a game. We had a very serious
sure.
conversation. So let's play a 1 minute game. Is I'll just give you two choices and you just give me which one you prefer. So
Mhm.
you don't need to think through about it. So we have 1 minute to play. Let me know when you're ready. Then we're gonna start.
I'm ready. Let's play.
Okay. Love or career?
Love or career?
Yeah. Which one would you choose? Save or spend?
At this point, yeah.
At this point, we're gonna save. We spent too much last month.
My spending years are over.
Okay. Morning person or night owl?
This is funny. Well, so back when I was spending, I was a night owl. Now that I'm saving, I'm a morning person.
Okay, so it
So
depends on your spending habits if you're morning or
I'm an
night.
adult now. I have kids
Okay.
and, so
I mean, it's hard to say as a surgeon, right? Because you don't know if it's like morning or night if you spend the whole day in a surgical room. So wine
yeah,
or coffee? Wine or coffee, though?
coffee.
Book or movie?
I want to say book, but it's probably movie. I really like
Okay.
movies, so I'd say it unashamedly. It's
Last
movies.
question. What's your favorite movie then?
My favorite movie. Um, I really love Paul Thomas Anderson. I haven't seen his movie, but Magnolia is one of my favorite movies. That's the one that comes to
Mm-hmm.
mind. It's just a really beautiful, kind of sad story about life, about all the different ways in which our lives intersect.
That's
If
why
your
you're in
listeners
medicine.
haven't, yeah, if you're
That's
like,
why you're in medicine, doc.
they should
So,
definitely check it out.
so thank you, doc, for being here. I really appreciate it. So before we leave, can you tell our audience where can they reach out to you? Is there something else you want to promote?
Sure. So I'm at Sina at imerit.net. Folks are welcome to reach out to me. I run our medical division. We work with experts around the world. We have what are called our scholars programs. If you're interested in working on building AI, please reach out. And if you need help building your AI application, reach out to us as well.
Are you looking for any interns? Most of my classmates are looking for internships right now.
Definitely, yeah, yeah. We sure are.
Okay.
Yeah.
So thank you, Doc, for being here. Take care, listeners. Since you're next episode. Goodbye.
Bye.